Hello, everyone. So we're going to start today our last series of chapters for the term. And we're going to emphasize antimicrobials. We're going to see medications that are going to be able to modify or destroy microorganisms. So we're going to start with the first one. And that is, penicillins. Okay, here we are. So the highlight of penicillins is a drug that breaks down the wall of bacteria. Keywords regarding mechanism of action or description of penicillins is that they have a beta-lactam ring. This is the part that attaches to bacteria and is able to take apart the bacterial wall. And penicillins is not the only family that has this ring. So as you can see here, we have cephalosporins, we have astronam, imipenem, meropenem, and ertapenem. So all of them, they have a beta-lactam ring that is the one that is responsible of destroying bacteria. Now, this is important to remember because if you remember from previous chapters, or maybe in class, I don't remember exactly when I mentioned it, that when a patient is allergic to penicillins, they have a cross-allergy reaction also to cephalosporins. And usually that's the most common question. But if they're allergic to penicillins, they're going to be allergic to cephalosporins, there's going to be allergy to astronam, imipenem, meropenem, and so on. Why? Because usually the allergy reaction is again the beta-lactam ring. So we'll continue back, we'll come back to that one. Usually the way the penicillins work, or any antibiotic that has a beta-lactam ring, that ring is going to attach to what we call the penicillin binding protein. So this is a part of the bacterial wall where the beta-lactam ring attaches and it breaks the wall down. So basically it rips the bacteria apart. And because of that, this group of antibiotics are called bactericidal, like suicidal, bactericidal. So they kill bacteria, they work fast. Now, let's jump over here. I'll be jumping between two slides. So the first time penicillins were used was back in the 1940s. And when they started using it, it was amazing because they cure everything regarding infections. You have to remember that 1940s, the main event going on at that time was World War II. So most of the casualties were not happening in the battlefield, but it was in the hospital. Wounded soldiers would get infections and there was no antibiotics to actually use there. So a lot of casualties, like I mentioned, were due to complications of a bullet wound that got infected. So when penicillins were introduced, a lot of soldiers were able to recover faster. And then once World War II ended, penicillins were used for everything. Doctors wanted to see what else that they could do with it. Unfortunately, with this, by the 1960s, 80% of Staphylococcus aureus in hospitals was already resistant to penicillins. So in 20 years, the overuse of this family produced a resistance. And how did this happen? Well, the main thing, what we're treating with microorganisms that just like us, they're able to evolve in order to survive. So they stay here in the production of penicillin binding proteins that have low affinity for penicillins. So basically what they were doing, they were making enzymes. They're making enzymes to prevent this union. So they're making enzymes that prevent the binding on the beta-lactam ring or the penicillin binding protein that the bacteria has on the wall. And the name of this enzyme that now is helping the bacteria survive is called penicillin. Give me a minute. Penicillinase. Remember, N-A's because it's an enzyme. So this enzyme, penicillinase, is the reason bacteria become resistant to penicillin. So again, the overuse of penicillins overall produce the bacteria to evolve and make an enzyme to fight the antibiotic. How? Penicillinase doesn't let the beta-lactam ring attach to the penicillin binding proteins anymore. And that's how we got resistance. So what happens after we have an antibiotic that we cannot use anymore? Well, we do something that is better than the first antibiotic. So we have methicillin. And if you notice, it's also ancillin, like penicillin. So they belong to the same family, but methicillin is stronger than penicillin. And same thing, once we started using methicillin, we were able to achieve, again, control of those infections and helping the patient survive. But again, the overuse of this antibiotic produce resistance, and that's what we have here, MRSA. So MRSA stands for methicillin-resistant Staphylococcus aureus. So this particular strain of bacteria is resistant to methicillin. And unfortunately, MRSA is becoming part of our normal flora in the body. Usually, we're gonna find it in the also of the nose and in the face. So we're seeing it more often, and unfortunately, if we get an infection, there's a chance that a MRSA is involved. So usually, when nowadays, we don't use penicillin right away for certain infections that we know, or for population that we know that have the risk of being involved with MRSA, like already people on the health field. So that's the story with regarding MRSA. So I goes telling you, bacteria, in order to fight back, they need to do a series of enzymes to fight antibiotics. And we mentioned that the name was penicillinases. We can be more specific regarding the name because the beta-lactam ring is the one that is destroying the bacteria. Well, the more specific name for this enzyme, it will be beta-lactamase. Enzymes that are in charge of destroying the beta-lactam ring and penicillins. So this will be the more specific name. Penicillinase is the umbrella name. So any type of bacteria that has a beta-lactamase already in their core, in their DNA, we're gonna have trouble treating them with regular penicillins. And as we move forward in this chapter, you're gonna see that we have a lot of variations regarding penicillin scattered in different families, and depending on the type of bacteria that is affecting the patient, even where, what environment, then we decide if we provide a simple penicillin or a more elaborated penicillin. So we have narrow spectrum penicillins with a penicillinase sensitive, Narrow spectrum penicillins that are penicillin resistant, broad spectrum penicillins, and extended spectrum penicillins. So usually the first two, I know is the same name, narrow spectrum penicillins, are the ones that we use for, for outpatients, simple sore throats, strep throats, stuff like that. Broad spectrum and extended spectrum, these ones are used for more complicated cases, especially those infections that are acquired inside a hospital. For example, it can be a pregnant mom. Start with labor contractions, they go to a hospital, no infections, but then the nurse is prepping the new mom to be, and they put a Foley to the urethra, and the mom delivers the baby, and 1 day later, now she has fevers. Now the mom has a urinary tract infection, a UTI. So because of the environment, instead of the doctor, instead of starting with a narrow spectrum penicillins, a penicillin that he will provide in his practice outside the hospital, he will start with the broad spectrum or extended spectrum penicillins, because this infection was acquired inside the hospital. So depending on the case scenario, depending on the patient and how they got the infection, that's when the doctor says, you know what, I can use a simple penicillin, or I can use a more elaborated penicillin. Okay, so penicillin G, or benzylpenicillin, is one of the most common penicillins used. This type of penicillin, penicillin G, can be found IV, intramuscular. So you might find it as potassium penicillin G. So careful on this one, just in case they ask, which penicillin can be used IV or intramuscular. That would be the most common one. Usually penicillin is very hard to find as a PO, unless it's a variation of a penicillin. So regarding penicillin, like it says here, it's the least toxic of all antibiotics, but unfortunately, is the most common cause drug regarding allergies. So when a patient is allergic to penicillin, make sure they understand if they have an allergic reaction to penicillin or they have an anaphylactic shock. And same thing, if the patient is allergic to penicillin, you must consider the patient allergic to cephalosporins and vice versa. Regarding the treatment of anaphylactic shock, is the epinephrine. Now, the allergy for penicillin can happen at any time. It can be a patient telling you, hey, you know what? I'm in my 50s and I've been taking penicillin since I can remember, and they can have an allergic reaction. It can be a newborn, they can have an allergic reaction. So not because they have a certain age, you assume, oh, most probably they don't have allergies, since they've been taking forever. Every patient can develop allergies to penicillin, to antibiotics at any time. So again, the treatment is the EpiPen. Regarding penicillin allergies, we have immediate reaction is 2 minutes to 30 minutes. Accelerated reaction, 1 hour to 72 hours, or delay may take days or week. So every time you administer penicillin or any antibiotic, the patient has to be in observation for the first 20 minutes at least. If they develop an allergy in this time frame, it's going to be a severe one, an anaphylactic shock. After that, go every hour to check on the patient, just in case they have an accelerated reaction. But again, the first 20 minutes are the crucial ones. Because again, you're never gonna know what type of allergy you're gonna develop. Regarding anaphylactic shock, we mentioned the main characteristic of anaphylaxis is hypotension, because basically there's a generalized vasodilation. That's a problem that we have with an anaphylactic shock. We have a severe vasodilation where blood pressure goes down, and all that fluid that is in the blood vessels now goes to the tissues. We have edema. So worst case scenario to have an edema, laryngeal edema, because now they cannot breathe. Um, Here should be bronchoconstriction, but again, the reason they have bronchoconstriction is because now they have edema in the bronchi. In worst case scenario, it would be in the bronchioles. This is the worst place to have an edema, because the bronchioles is the breathing portion of the lungs. So if we have a severe anaphylactics and we have edema all the way down to the bronchioles, and the patient's gonna be unable to breathe. So again, it goes in steps. You can say that. Start with the larynx, go to the bronchi, and then the bronchioles. So again, this may happen within 20 minutes on severe anaphylaxis in the first 20 minutes if the patient's going to have an allergic reaction. We mentioned the treatment is going to be epinephrine, the EpiPen, and respiratory support. Sometimes we have to ventilate the patient, use a ventilator. And well, sometimes we can do skin test. Yes, in case the patient does remember if they're allergic to penicillins, but they mentioned, hey, I remember they give me an antibiotic and they had a reaction. So it's better to do a skin test. Regarding drug interactions, aminoglycosides, this is another antibiotic that is going to have a severe interaction with penicillins when the presentation of both of them are IV. So never give aminoglycosides with penicillins at the same time. When you mix aminoglycosides with penicillins IV at the same time, the two of them are gonna crystallize in the vascular system. So it's like injecting a bunch of broken glass into the patient's vein. So very careful on this. I only saw that question only once, that you have in order to give penicillin at 9 a.m. and aminoglycoside. Aminoglycosides, we're not there yet, but they end in mycin. So you have a penicillin and a mycin IV at the same time. What do? You don't give the medication, you question the order, you tell your charge nurse about the interaction so they can call the doctor, and change the time frame of the two antibiotics. One can be the morning, the other can be at noon, no problem. The problem is at the same time. So that'll be the most common drug interaction that you need to remember. Aminoglycosides, medications that end in mycin, IV at the same time as penicillin, you cannot do that. Now, like I mentioned, the overuse of antibiotics is producing resistance. And we have, and this is a tongue twister, penicillinase resistant penicillins. So these are penicillins that are designed for those infections that already have proven to be resistant against penicillin. So yeah, on this one, you need to remember all three of them: nafcillin, oxacillin, and decloxacillin. Or, not, if you want to remember the initials. So penicillins that can fight that enzyme, that penicillin enzyme is nacillin, oxacillin, and decloxacillin. From these three, the one that I have seen the most in questions is decloxacillin. That's the one that I've seen more often. So those are the three penicillins that can be used for MRSA. MRSA would be the best example. Regarding a broad spectrum penicillins, we have ampicillin and amoxicillin. So if you're a mom with kids, most probably you are very familiar with this too. Ampicillin is used on a hospital setting. And amoxicillin is more as an outpatient presentation. So usually when the patient is taking ampicillin in the hospital and they're discharged, they will continue with amoxicillin. Regarding the adverse effects, rash, that means allergies. Just make sure it doesn't go or the patient has symptoms of anaphylaxis. And diarrhea. Now regarding diarrhea, I know it's not too specific here, but when the mom calls you or is telling you, hey, my kid, after starting the antibiotic, and this can happen with any antibiotic, not just with those two. When my kid or myself started taking the antibiotic, I started with diarrhea. So that's a red flag for you. As soon as you hear diarrhea because of antibiotics, you need, oops, not here, it's not this one. Where's it? Oh, probably erase it. You need to do a triage for pseudomembranous colitis. So when the patient tells you, I'm having diarrhea due to the antibiotic, you need to do a triage regarding pseudomembranous colitis because this is considered a super infection. And again, super infections are secondary to antibiotics. So that means that we need to stop the antibiotics. So what's happening here? When a patient takes antibiotics and the antibiotic goes into the body, they don't select what bacteria to kill. If they can kill a bacteria, they'll kill the bacteria. The thing is, we have normal flora in our gut. And when the antibiotic goes there, it's going to kill, again, all the normal flora that it can because normal flora is bacteria. And that's what antibiotics are designed to kill bacteria. So when they go in and they start destroying the normal flora, now we have an imbalance. The thing is, the good bacteria dies, and usually Clostridium difficile survives. And Clostridium difficile by itself can be fatal. So how do we know that a patient has pseudomembranous colitis? Well, patient is telling you, I'm starting to take an antibiotic, and I'm starting to have diarrhea. And well, describing the diarrhea is fluid, and then they're gonna emphasize the smell. Oh my God, it's horrible. So this is a very, very smelly diarrhea. Well, in hospitals, Clostridium difficile, they call it C. diff. So that's an easier way to say C. diff. The patient has C. diff instead of no, the patient has pseudomembranous colitis. So when a patient is taking antibiotics, we need to prevent this. We don't want this patient to go to pseudomembranous colitis. We don't want the patient to have C. diff because it can be fatal. So when this happens, we remove the antibiotic that is causing it, and we continue with metronidazole. That's the treatment for C. diff, metronidazole. As we move on to the other chapters of antibiotics, I'll continue talking about pseudomembranous colitis. Okay, we have a bacteria out there called um, Pseudomonas. Usually this yeah, usually the bacteria is found on hospitals. You're never gonna see a Pseudomonas infection outside of hospitals in the community. So it's an infection that is exclusive from hospitals. Usually it's very common in burn patients. So that's when you're gonna see it the most. Pseudomonas has a fruity odor. That's how some doctors they describe it when they have this infection has a fruity odor. Some will say has almost a rotten apple odor. They smell like apples, not rotten yet, but getting there. Or other people say, it's more like a grapes going into that phase of getting rotten. And the infection has a very specific color. Uh, bluish, greenish color, kind of slimy. So this is a bacteria that lives on hospitals and it's very hard to treat. And again, burn patients, they don't have the skin for protection, so it can produce a severe fatal infection for those people in that unit and can be fatal. Oh, here's the complete name: Pseudomonas aeruginosa. That's the complete name of Pseudomonas. So for this type of a bacteria, we have a very specific penicillin called piperacillin. So regarding penicillins, piperacillin is the main penicillin to treat Pseudomonas infections. The most common patients are patients in the burn unit, and usually the infection that you're gonna see is gonna be a bluish, greenish characteristics with a apple, grape odor or fruity odor, and it's a little bit slimy. Piperacillin has been used for other type of bacteria that are hard to treat too, but we're not going to continue talking about those ones in this chapter yet. Now, another way of fighting bacteria that is resistant is combinations of two antibiotics. That way, one antibiotic can treat the enzyme that is making the resistant, and then the penicillin can destroy the bacteria. So we have here 3 specific antibiotics that are designed to inhibit the beta-lactamase. Remember, beta-lactamase is a specific name, or penicillinase. So this three, clavulanic acid, tazobactam, and sulbactam, they will inhibit the enzyme that is producing the resistance, and then now the penicillin can destroy the bacteria. The most common combination is amoxicillin with clavulanic acid. That's the Aumentin. Very, very common drug used nowadays for those infections that are resistant. And like I told you, depending on the doctor, depending on the case scenario of the patient, they can jump right away to this combination and instead of giving just amoxicillin by itself. The other two combinations is ampicillin with sulbactam or piperacillin with tazobactam. Okay, and that will be all for this chapter. See you in the next one.